Increased MCV indicates macrocytosis, which is often caused by vitamin B12 or folate deficiency. This is also called megaloblastic anemia. These deficiencies can result from poor nutrition, malabsorption, or competitive parasites. Alcoholism and chronic liver disease are other common causes of macrocytosis, and they're often multifactorial in origin. Certain chemotherapy drugs and anti-metabolite therapies also interfere with folate and B12 pathways, which raise MCV. Recognizing macrocytosis is an important step to identify those underlying conditions. A decreased MCV indicates microcytosis, which means the red blood cells are smaller than normal. The most common cause is iron deficiency anemia, particularly later on in later stages, but thalassemia is another important cause where genetic mutations impair hemoglobin production. Anemia of chronic disease can also present with microcytosis, but it's often more normocytic. And microcytic anemias are generally associated with impaired hemoglobin synthesis, and this is often the first red flag pointing us in that direction. MCH could be either increased or decreased depending on the anemia type. Increased is seen with a macrocytic anemia versus decreased in microcytic anemia or hypochromic anemia, where cells are both small and pale. MCH often tracks with MCV, and it just adds another layer of info about how much hemoglobin is present inside each cell. Increased MCHC is less common but can occur in certain conditions. One example is hereditary spherocytosis, where red cells are sphere-shaped instead of biconcave, giving the impression of a more concentrated hemoglobin. Intravascular hemolysis, where free hemoglobin is released into the blood, can also artificially elevate MCHC, and cold agglutinins, which causes red cells to clump together. This can also lead to a false elevation. These conditions highlight the importance of correlating lab results with clinical context and peripheral smear findings. A lower MCHC indicates hypochromia, which means red cells appear pale on smear because they have less hemoglobin. This is a hallmark for iron deficiency anemia. It's also commonly seen in thalassemia. It often will come with microcytosis, but they don't always go hand in hand. And lastly, an elevated RDW suggests greater variation in red cell size or anisocytosis. Iron deficiency anemia is actually one of the more common causes as bone marrow produces both small iron deficient cells and newer variable sized cells. B12 and folate deficiency anemias also raise RDW because the marrow produces a mix of abnormally large and smaller cells, and hemoglobinopathies and hemolytic anemias can have a similar effect, especially after hemorrhage when the marrow is rapidly producing new cells. Looking at some overall patterns, not all anemias are micro or macrocytic. In fact, many are in the normo-normo category, normocytic, normochromic. This is where cells are normal in size and color, but fewer in number. Causes include early iron deficiency anemia, anemia of chronic disease, acute blood loss, and aplastic anemia, where the marrow stops producing cells altogether. Renal disease is another major cause because of reduced EPO. And in these cases, the indices look normal, but the overall cell count is reduced. A classic example is microcytic hypochromic anemia. This is almost always due to late stage iron deficiency or thalassemia. Lead poisoning can also cause this pattern by interfering with hemoglobin synthesis. In this, both MCH and MCHC are decreased. So cells are both small and pale. Microcytic normochromic anemias are less common but associated with chronic illness. And in this setting, cells are small but contain a normal concentration of hemoglobin, so their color is preserved. Chronic inflammation alters iron metabolism and reduces red cell production, leading to this subtle but distinct pattern. And it's a great reminder that not all microcytic anemias are iron related, as chronic disease must always be a part of the differential. Lastly, we have, oh, maybe lastly, oh, lastly, this should be a macrocytic. So we're going to change this. That's why I was confused. This is a macro with an A, acidic hypochromic anemia, and this pattern is often linked to vitamin B12 or folate deficiencies, which impair DNA synthesis and can cause large immature red cells. Certain medications can adjust this and interfere with folate metabolism, producing the same effect. Alcohol toxicity and thyroid dysfunction, as well as myelodysplastic syndromes, can be other possible causes. Red cells are large and pale, which with impaired oxygen carrying capacity. Recognizing this allows for prompt testing. So we've reviewed the key components of a CBC here, from hematocrit, hemoglobin, platelet counts, red blood cell counts, and the indices to help classify anemia. Every parameter offers its own insights, but together they provide a comprehensive picture of the patient's hematologic health.